And I'm one of the endocrinologists at Texas Diabetes and Endocrinology.
My name is Tira Teicher-Brown. I'm also one of the other endocrinologists at Texas Diabetes.
And I'm Bridget Brady. I'm an endocrine surgeon here in Austin.
So I'll start first. I'm going to start with hypothyroidism, and feel free to interrupt us or ask questions as the presentation goes on. So I'll start off with talking about the thyroid hormone. So the thyroid gland basically sits in the neck, and Dr. Brady is going to go over that in a little bit more detail as far as the anatomy is concerned. But as far as the thyroid hormones that are released, what we talk about is the control of the thyroid, which actually comes from the brain. So you have the hypothalamus, which sits up in the brain, and then there's a little stalk called the pituitary that sits right behind your eyes. And that pituitary releases, in addition to the hypothalamus, the pituitary releases the actual thyroid hormone that stimulates the thyroid to release thyroid hormone. So TSH stands for thyroid stimulating hormone. So it's stimulating the thyroid gland in your neck to release the thyroid hormones themselves, which are T4 and T3. And those are the hormones that actually do the work of controlling your metabolism, helping with your muscle function, your eyes, your heart. They affect every organ and every cell in our bodies. So if you do not have enough T4 or T3, meaning if you have hypothyroidism, there are different causes for this. The one that's the most common is going to be something called Hashimoto's thyroiditis, which is an autoimmune form of the thyroid disease. Basically, you have antibodies, which are molecules that you most of the times have been inherited from a family member or somebody in your family, and it attacks the thyroid and it basically destroys the thyroid so it doesn't function very well. That's the most common reason. And then the other few reasons you can have hypothyroidism are surgery if you have the thyroid gland obviously removed, or if you have radiation. The thyroid is very responsive to radiation treatments. And that can destroy the thyroid, or certain medications. The ones that are the most commonly associated with thyroid dysfunction are going to be amiodarone, which is used for congestive heart failure, or lithium for psychiatric illnesses. So if you don't have enough thyroid hormone, some of the symptoms that some people can have are fatigue, a modest amount of weight gain, some constipation, feeling cold all the time, dry skin, depression, and some irregular periods. The regular periods are usually with heavy flows. These are all, we call them non-specific findings or non-specific symptoms. And so if you can imagine, some of these things might be caused by other things. So if you don't sleep very well, if you don't follow a very good diet, if you're not drinking enough water, people can obviously get some of these symptoms. Or sometimes even some of these symptoms may be very mild or not so obvious. And so blood work to make sure that these symptoms are due to the thyroid. And so the way we diagnose hypothyroidism is we check that TSH that comes from the brain. And then also, sometimes we can check a T4 level or a free T4. And the typical pattern that we would see is an elevated TSH because the thyroid is not producing the thyroid hormone. So the brain is trying to tell the thyroid to push out more thyroid hormone. But since the thyroid is not working, your T4 is going to be low. And so this often gets very confused when people are discussing over the phone. When if you say my thyroid levels are low or my thyroid levels are high, what does that really mean? So if the thyroid levels are low, it actually means the T4 is low, but the TSH on your results might actually be high. And so how do we treat hypothyroidism? So we basically give back the thyroid hormone that you're missing. The most common thyroid hormone replacement medications are levothyroxine, which is the generic, Synthroid, which the other ones are name brands, Synthroid, Lavoxyl, Armour, there's Westhroid, there's a lot of different formulations. And so once these medicines are started, it takes a little while for the brain to adjust and reflect those changes in the blood work. And so usually we repeat this blood work in about 6 to 8 weeks to make sure that the dose is adequate. And so this is not something that we just start a medication on. You actually have to follow the blood work and make sure that it's still at a good dose. And in most cases, once the thyroid medicine is stopped, once the medication is started, it's usually taken for lifelong. There are certain conditions where maybe they may not have to be taken for forever, and most of the times it is taken forever. And some of y'all might be on thyroid medicine. It's very important to take it properly. And so we usually recommend taking it on an empty stomach first thing in the morning. And it's a very finicky medication, so it can be affected by certain medications as far as absorption. So iron, calcium, multivitamins, which usually have a little bit of calcium or iron in it, or heartburn-related medicines need to be taken at least 4 hours separate from the thyroid, or usually I say take it at night and take the thyroid medicine in the morning. And typically if you miss a dose, because it's a very stable hormone, it takes a lot of time for it to go into the cell and do its thing. If you miss a dose, you want to make sure you make it up the following morning. There are several medications over the counter that you can get from specialty pharmacies that are kind of natural thyroid hormone. It's not really recommended for patients to try it, only because sometimes it can contain thyroid hormone that will affect the way your body chemistry is, and can either make your symptoms worse or put you at risk of having too much thyroid hormone around, which can be a problem.
Questions?
Yes. It's my understanding that there are a couple of different kinds of blood tests for determining hyperthyroidism. And there's one that's just kind of like a screening, and then there's another one. So which one, if we think there might be an issue, which one should we be
So the one that you're talking about, the screening, is probably the TSH, the thyroid stimulating hormone.
Okay.
That's probably, if I had to put, so there's a lot of different thyroid hormones like T4, T3, and reverse and things like that. The TSH, if I had to put money on it, I would say the TSH is the first thing that most people would do. And that's probably the majority of the times the thing that would cinch the diagnosis. The free T4 would probably be the next. Is it really necessary to check it? No, not all the time. But depending on who you ask, as far as physicians are concerned, I would definitely start off with TSH and plus or minus the free T4. There are some other labs that used to be checked back in the days that we don't often check anymore because they're not as reliable, and we just have better tests available now. So Dr. Harrison's going to talk about hyperthyroidism.
So this is just kind of building off what we just went over. We're looking at the same system here, the same flow of hormones. We're just talking about the other side of the coin. So the causes of hyperthyroidism, again, the most common cause is also an autoimmune disease, just like Hashimoto's. So it's called Graves' disease. So you make antibodies to your thyroid that just make it make thyroid hormone without listening to the pituitary. So it's mostly in females. You can see the ratio is 10:1. And it is the only form of hyperthyroidism that's associated with ophthalmopathy, so where your eyes kind of bulge out, and it's because that antibody that makes your thyroid work too hard also causes the muscles around your eyes to be infiltrated, and it just kind of pushes the eyeballs forward. So that's a very dramatic picture of it there, showing, you can see the goiter in the neck. They do have thyroid enlargement, and then also the eye symptoms that can be pretty severe. So that's the most common. The next most probably is toxic nodule or a multinodular goiter. So either one nodule in the thyroid that's just making too much thyroid hormone without listening to the pituitary, or several nodules in the gland that are doing that. And then the third one is thyroiditis. So that one's a little bit more difficult to diagnose, and it's usually a transient thing. It can be from a lot of different things, but it's an injury to the thyroid gland that makes it spill out all its thyroid hormone, and then it usually recovers on its own. The most common cause is probably viral or postpartum. It can happen, and I'll talk a little bit more about that. It can be drug-induced, and those are the two drugs that Sarah mentioned earlier. The amiodarone and the lithium are the two that do it most often. Also, iodine can do it. So the most common is after somebody's gotten a CT scan for something in the hospital, that's a big iodine load, and it can injure your thyroid and give you some transient hyperthyroidism. And then, of course, if we give you too much thyroid hormone, that can do it. Sometimes we do that on purpose for thyroid cancer that we'll talk about later, or not on purpose, which you just need a lower dose of thyroid hormone. So symptoms of hyperthyroidism are, as you can imagine, kind of the opposite of the symptoms of hypothyroidism. So losing weight without trying, frequent bowel movements, just feeling really anxious, feeling shaky, having palpitations, especially at night when you're trying to go to sleep. Hair loss can definitely happen, feeling weak. Sometimes it can present with memory loss. And then irregular menses are on the other side, usually light periods or missing periods. So diagnosis is pretty similar to diagnosing hypothyroidism. TSH is usually the first reflex test done. And then if your TSH is low, you should check your free T4 and your free T3. So it's a little bit different than hypothyroidism. Usually we check both of those together because either one could be elevated. There is subclinical hyperthyroidism where you have a low TSH but normal free T3 and free T4. And it's the same causes that we discussed earlier, just a less severe form. You know, and we treat it a little bit differently, just less. So then after we diagnose that you have hyperthyroidism, we want to know why. There's two main things that we do to determine that. The first one that usually gives us the most definitive diagnosis is a radioactive iodine uptake scan. So we give you a real small dose of radioactive iodine and then see what your thyroid does with it. So in Graves' disease, because the whole gland's making thyroid hormone, the whole thing lights up. If it's a nodule that's doing it, a nodule lights up. And then if it's thyroiditis, it's black because you're not making any thyroid hormone. Your thyroid's injured and it's spilled everything out. And, so it's pretty easy to tell which one it is based on that test. The other thing we can do is the antibody test. So if we're pretty sure it's Graves' disease, there's two antibodies, the thyroid stimulating and the thyroid receptor antibodies that we can check. That if you have those elevated, that's Graves' disease. So one of those two will use to determine what the cause is. So how we treat it depends on what the cause is. So talking about Graves first because it's the most common. So we can either treat it with medication, with radioactive iodine, or with surgery. Medication's nice because about 30% of people with Graves' disease will go into remission on medicine after taking it for about 18 months. Usually it's people that have only mildly high thyroid levels, don't have a real big goiter, kind of mild disease. That's who we shoot for remission the most in. And the medications do have side effects, so we usually don't keep people on them lifelong. If it doesn't cause remission, we might move on to one of the other treatment options, which are radioactive iodine, which in most cases people end up hypothyroid on that, so you would need thyroid hormone replacement that Tara talked about earlier. Or surgery can be done as well. I wrote some reasons why you can do surgery instead of radioactive iodine. If you're having compressive symptoms because your thyroid is so large. If there's malignancy during pregnancy, it might be a treatment to consider. Or if you have really bad that proptosis that we saw earlier, the eye symptoms, because that can be made worse with radioactive iodine. Treatment of the other form, so if it's a toxic nodule, radioactive iodine works really well because it'll kill that nodule, the rest of your thyroid will keep working. Multinodular goiter, we can do iodine or surgery. And then thyroiditis, as I mentioned earlier, that usually resolves on its own, so we just treat the symptoms while you're hyperthyroid and then watch you closely after because you can get hypothyroid. And then you might need thyroid hormone for a little while or permanently. So I just put a couple of special topics here that have to do with thyroid. Okay. So the first, I just wanted to mention a few things about pregnancy and the thyroid because it's a little bit different. So before pregnancy, we like your TSH to be low. So if you look at the range of TSH on a lab test, it's pretty wide. It's usually something like 0.5 to 4.5, but before pregnancy, we like it to be less than 2.5. And then during pregnancy, the goals are even lower. So if you're already on thyroid hormone, you need to be monitored more closely during pregnancy because you'll probably need more thyroid hormone. And the other thing is, as far as iodine goes, in the general U.S. population, we don't recommend any additional iodine from what you get from your diet. It is in salt, and it's also in a lot of our dairy products. There are two big sources of it. But during pregnancy, it is recommended by the American Thyroid Association that you should take additional iodine. Most, but not all, prenatal multivitamins have iodine in it, and it's recommended to get 150 micrograms to support your thyroid. And then the other important thing is postpartum. Getting thyroiditis is really common. As I mentioned, thyroiditis is common postpartum earlier. So 6 to 10% of people will have it. Sometimes it's not caught if it's mild. But people who get it more, people that have the Hashimoto's antibodies, that's the TPO antibodies, And often they'll remain hypothyroid afterwards, so they have to be monitored for at least the first year after pregnancy, and it will often recur with the next pregnancy. So that's something you have to watch out for.
Something I wanted to add about the iodine is, even though it's recommended for 250 micrograms, doesn't mean that if you take 500 micrograms that'll be okay. You can get too much iodine in your supplementation, so you don't want to take. You don't think that if a little bit is okay, that more is going to be even better.
Yeah, it can cause thyroiditis, getting too much iodine in your diet, just like when we see teaspoons.
And so, as far as a lot of times we get questions about certain things in our diet, whether soy or gluten can affect your thyroid. And so there's not a whole lot of evidence or evidence-based medicine regarding how soy products affect the thyroid. However, when they did look at infants who were hypothyroid, who were actually on a soy formula, their thyroid was not very well regulated because the soy was impeding the absorption of the thyroid hormone. So we know that there's some sort of effect with the absorption of thyroid hormone with soy products, but there's nothing to say that that you have to avoid soy so that your thyroid levels can be better. And then as far as gluten in the thyroid, so you'll find there's a lot more research that has gone into looking whether or not gluten affects how the thyroid hormone works or the effects of the medication and the absorption. So celiac disease is actually the true diagnosis for somebody who is gluten intolerant or resistant, or where they cannot tolerate gluten because it affects their intestines from absorbing certain nutrition. And so with celiac disease, they actually looked at that and they found that people who were not following a gluten-free diet did not absorb their thyroid hormone very well. So if you actually have celiac disease and you're not following a gluten-free diet and you have thyroid problems, it's going to be a lot harder to make sure your thyroid is working or treat you with thyroid medication. And then otherwise, if you just follow a gluten-free diet and you don't have celiac disease, I don't think there's really any studies that have shown that going gluten-free is going to make your thyroid function or absorb the thyroid hormone any better.
Okay, I'm going to talk a little bit about thyroid nodules and why you would see an endocrine surgeon or a surgeon about your thyroid. So what is the thyroid? We kind of talked about that a little bit. It's the gland that's on the front of the neck. It's a butterfly-shaped organ. It helps us with our metabolism. We need it for all our organ systems in the body. And as we talked about, it secretes thyroid hormone, but it's controlled by the brain, like we talked about earlier. And if you do have your thyroid removed, you have to be on medication for life. So this is a little picture of what the thyroid looks like in a diagram or photo. That's the thyroid gland laying over the windpipe of the trachea. And there it is. How to diagnose thyroid disease, as we talked about earlier, you want to see your primary care doctor for your yearly exams. Sometimes they'll order blood tests once a year, including that TSH level that we talked about earlier. And if the doctor that's examining you feels a lump on your neck or somewhere around your thyroid, they'll typically order what's called an ultrasound. And it's an easy way to look to see if there's any enlargement in the thyroid or problems with lymph nodes in that area. If one of these tests comes back positive, typically they'll send you out to have a referral with an endocrinologist or an endocrine surgeon. So talking a little bit about goiters, goiter is just an enlargement of the thyroid gland. It can be because of nodules or because of Graves' disease, just a problem with your thyroid. When your thyroid disease can get overactive or underactive and enlarged. Sometimes some of these patients, like I said, have normal function. Sometimes they have hyperthyroid or overactive thyroid and can have underactive thyroid as well. We see patients that sometimes have problems with swallowing or breathing once their thyroid goiters or nodules become too large. It can actually give them symptoms. So nodules are any abnormal growth of the thyroid cells that forms a lump within the thyroid gland. They usually don't cause symptoms. They're very common. We see them quite a bit. By age 60, about half of the population will have a thyroid nodule that can be found during examination or on imaging. So it's very, very common. Other causes, like we talked about, iodine deficiency and Hashimoto's, these are patients that might present with nodules also. Symptoms of thyroid disease, most patients tell us they don't have any symptoms. It's typically benign. Most of these nodules are nothing to worry about. Those are the most common, about 90%. A lot of my patients say they had a carotid Doppler or a screening ultrasound for some kind of health fair, and they found some nodules in their thyroid. So you just want to get them checked out. We're just trying to rule out a thyroid cancer, but the majority of these, like I said, are not cancers. If they are a cancer, most of the patients describe not having symptoms at all. Sometimes patients will find a lump on themselves, or their doctor may feel a lump on their neck, and that might lead them to a thyroid ultrasound and then a biopsy. But typically, like we talked about, the blood work is typically normal in cases of thyroid cancer. A lot of doctors will ask patients a lot of questions about their history, including radiation exposure or family history of thyroid cancer. That would kind of lead us down the road to be more concerned about a malignancy in the thyroid. So the first thing we do to kind of evaluate these nodules is what's called an FNA biopsy, or fine needle aspiration. Basically, we numb up the skin in that area using an ultrasound. We guide a needle into that region. And the endocrinologists do these biopsies, and we do these biopsies, typically on patients that have nodules that are getting larger, those that can feel a nodule. Sometimes if they're symptomatic, if they feel like there's something choking them, we'll take a sample of it. Any suspicious lymph nodes, those are some reasons why we might do a biopsy in the office. Questions that the doctor will ask about them is if the patient's having any problems swallowing or breathing, if they're having any hoarseness or voice changes. They say they can't swallow their food or they're choking. Sometimes patients will have thyroiditis and actually get neck pain in the anterior portion of their neck. Patients that have these different symptoms, we want to ask also about the family history, like I touched on before, touching on especially thyroid history and thyroid cancer. Okay. The ultrasound is very sensitive. This is a test we can do in our office. It's inexpensive, non-invasive. There's no radiation exposure to it. It's painless for patients. And typically it helps us describe these nodules. So we can describe the nodules as being solid, or if they have cysts or fluid in them. Characterize it as looking suspicious or not. Some of the characters of the cancer, there's a long list here, but you want to worry about sometimes if we see calcium or irregular borders, enlarged lymph nodes, those are things that we might be more concerned about with the patient and follow the surgery or biopsy these lesions. These are a couple of photographs of what an ultrasound actually looks like. The one on the right here is pure cystic. It's dark in the middle. The nodule actually is a solid round thing, and it's just pure fluid that's inside of that nodule, completely benign appearing. This one on the left side is more of what's called a spongy form appearance. It looks the same almost as the thyroid around it. For biopsies, if we don't get enough tissue, we typically will repeat it. If they're benign, we tell the patients it's probably okay to just watch this if they're not having any symptoms. So typically we'll just see them back and follow up and monitor it for growth or symptoms at that time. If it's cancer or suspicious, we do recommend surgery or removing that part of the thyroid. If it's atypical cells, we might repeat a biopsy or operate on the patient depending on their preference. And once we do remove the thyroid for thyroid cancer, like I said, patients will be on thyroid medicine for life, usually Synthroid. This is a couple of pictures of what calcification would look like. They're white speckles. I don't know if you guys can see on the left side. It kind of looks like little stars. That's when we get more worried about a calcified nodule. And this nodule has hypervascularity or increased blood supply. We might be more concerned with the cancer once you see a type of nodule. Or with toxic nodules, we see that as well. This is what's called a hypoechoic or solid nodule. It's usually darker than what's surrounding tissue of the thyroid. So when would you need surgery on your thyroid? If you're having problems swallowing or breathing in an enlarged goiter. Some patients that are very thin can notice the nodule in their thyroid and they might want it for cosmetic purposes. Hoarseness, problems with breathing, any rapid growth, or if we're trying to rule out a cancer, that's when we would typically operate on the thyroid. There are anywhere between 118,000 and 166 patients in the U.S. have a thyroidectomy each year for benign or malignant causes. So it's a very common operation. There are different types of thyroid surgery we do. Typically, we would perform a lobe or removal of half of the thyroid gland if patients have an enlarging nodule just on one side and we haven't when we don't have a diagnosis of cancer, then we may just remove that one side of the gland. Or if a patient just has a goiter on one side and they're having symptoms, and we may just remove that side. The goals of that are to try to give them enough thyroid tissue remaining so they have a chance of not having to take thyroid hormone the rest of their lives. If we do a total thyroidectomy, that's removal of all the thyroid tissue in the neck, and that's mainly for Graves' disease or patients that have a problem with large goiters causing compressive symptoms like we talked about, or for thyroid cancer. Typically, neck dissections, which are removal of lymph nodes in the neck, are done for metastatic cancer of the thyroid. Other cancers as well. Additional treatment for thyroid cancer after an operation, once someone has all of their thyroid removed, they need to be on thyroid replacement for life, as we talked about. They'll need to follow up with an endocrinologist routinely to kind of watch them for this. They get blood tests to make sure that that TSH level is kept very low. The reason we want to keep that low is because in the beginning, as Dr. Chachabraham talked about, that brain level will increase the activity of your thyroid. So if there are a few thyroid cancer cells in your body, we want to suppress those and have them not grow. There's options for radioactive iodine, depending on the type of cancer you have and how aggressive it is, or how large or small, or if it's involving lymph nodes. They may end up giving you a radioactive iodine pill. You actually swallow that pill. There's no chemotherapy that we typically treat for cancers of the thyroid. For the most common cancers, it's rare to give chemotherapy.
I have a question.
Yes.
So regarding the TSH level, you said that it should be very low. How long does it, you always have it low after you have thyroid cancer, or does it change as you?
It can change, but I'll let you guys touch a little bit more on that.
Yeah, it definitely depends on how bad your thyroid cancer was. If there's a wide range, if it was a very small cancer, sometimes we don't even keep it suppressed, all the way to the very large ones where you might be suppressed for life, and it is an evolving thing. So even if it's bad and then 3 years later you're disease-free and everything, we loosen up on it, mostly because keeping your TSH real low can cause osteoporosis and irregular heartbeats. So we try to kind of balance, you know, the aggressiveness of the cancer with the possible side effects you could have later.
So this is a picture of a patient of mine that had a goiter, and if anybody has I don't have to show the next slide. It's a picture of her goiter after it was removed. But she was one of my recent patients I operated on, and she was actually from Mexico, and she was having trouble swallowing and breathing. And it was really an impressive, from this picture, it's not, you can't appreciate this, but it was a very large goiter that we removed from her neck. And are you guys okay with this, or should I? Everybody's okay? Okay. That's her goiter once we removed it, but on the, this is about 6 inches on the little measuring stick there. So a very large gland that was causing her problem swallowing and breathing. And then that's all I have.
The normal size.
The normal size, I guess, what do you guys tell patients that would be the normal size of a
I
thigh?
usually say 4 by 2 by 1 centimeter for each lobe.
Yeah,
For each
side.
side.
Yeah, it's confusing in centimeters.